Welcome everyone. This is Selena Siddika, a member in Health Economics Research Network HERN and a PhD researcher at the Center for Health Economics, University of York. I appreciate all of your kind presence today here despite the busy schedule. And on the capacity building front, under the umbrella of HERN, this is the regular webinar arranged by this network in collaboration with University of York. This webinar has also been supported by Arc Foundation, DiaDeM also. Today, we have the honor of the presence of Dr. Rowena Jacobs, Professor of Health Economics and the Deputy Head of the University of York, as our distinguished speaker. Besides, we are privileged to present Professor Simon Walker from Center for Health Economics, University of York as well. Welcome, Rowena. Welcome, Simon.
Thank you very much, Selena.
So now I'm going to briefly introduce our honorable speaker, Professor Dr. Rowena Jacobs. Professor Rowena has expertise in mental health economics and mental health policy. She contributed with her scholarly research in the field of evaluation of mental health policy reforms, incentives, and performance measurement of mental health services. Professor Rowena has undertaken various research projects with significant policy impact and won several awards, like the William Manning Award in Mental Health Policy and Economics Research in 2019. She also acted as an advisor to various UK government and other agencies, as well as the World Bank, WHO, and OECD. As you know that mental health problems have significant economic impacts due to the huge burden of ill health and disability caused. Professor Venus' today's discussion will cover some of the key characteristics that differentiate mental health from the physical one, as well as the key economic considerations for mental health and the provision of mental health care. With these words, I would like to welcome Professor Rowena Jacobs. I hope that you will enjoy the presentation. Thank you so much for your kind attention. Rowena, now floor is yours. You may start now. Thank you.
Thank you. Thank you so much, Selena. Thank you for that very kind introduction. I'm going to start sharing my screen.
Yes.
Great. So thank you so much. And thank you for this opportunity to talk to all of you about something which I'm obviously very passionate about, which is the economics of mental health. So I'm coming at this very much from an economics perspective. I'm in fact probably not going to talk about my own work at all today. I really want to sort of provide a bit of a framework for thinking about mental health and why mental health might be slightly different to physical health, and how, as economists, it might help frame how we should sort of think about mental health in terms of the economic challenges that it raises. So I hope I provide some food for thought. It's going to be quite a sort of general and high level discussion rather than going into any particular specific aspects. But let me first start by us thinking about, well, what is mental health? And it might seem quite obvious in many respects, but I think as economists, we actually need to think about it quite carefully. So if we just take simply a WHO definition of health, it is the state of complete physical, mental, and social well-being, not merely the absence of disease. So I suppose by extension, if you think of that, then mental health is more than the absence of mental disorder, and it's an integral part of health. And there's no health without mental health. So I think actually, as economists, we need to think quite carefully. And if you think more broadly, a lot of disciplines will differ in terms of how they define mental health. So psychiatrists and psychologists will think differently about it. And indeed, if we were just to take a DSM or ICD perspective on how we define mental disorders, indeed that probably differs between countries, how we think of mental illness, and differs between disciplines, and it differs over time. So indeed, these definitions change with social norms. So what we may have considered mental illness 100 years ago is not what we would today. So I think as economists, we need to think a little bit more carefully, and I've used the word unsystematic here, but I think perhaps I could be a little more harsh and actually say we've been quite sloppy in our definitions of mental health. So, if you look at publications, they might include things around mental well-being, subjective well-being, psychological well-being, life satisfaction, quality of life, loneliness, happiness. All sorts of things get thrown into the banner of mental health. And I think perhaps we need to be thinking more carefully about what we mean by mental health, something which I'm keen to devote a little bit more of my time and energy into. But assuming we now know, we have an idea of what is mental health, and as economists we're agreed on mental health, then I suppose the next question I want to phrase is, well, is mental health any different to physical health? And I want to take a perspective here, which is to frame my thinking around a paper by Kenneth Arrow from 1963, which is a very old paper now, but I think it really, many would define it as this sort of birthplace of health economics as a discipline. So this American Economic Review paper has been cited more than 12,600 times. It is an absolutely foundational paper for those of you who are not familiar with it. But in this paper, he essentially tries to think of how medical care differs, that the market for medical care differs from the market for, say, widgets or something else. And there's a whole range of characteristics around medical care that means it essentially departs from the competitive paradigm, and the characteristics result in essentially market failure. So there's a whole range of characteristics. Individuals can't be in a position to adequately assess their needs. There's this agency relationship between the doctor and the patient, where the patient actually demands health, but by extension, there's a derived demand for health care, which as part of this agency relationship, the doctor provides. There's the information asymmetry between the patient and agent. It's really complex. There are externalities. There's a great degree of uncertainty. And so as a result, there's a huge amount of government intervention, whether it's in the organizing or the financing or the provision of healthcare. So my question is really for us to think about, well, is mental health any different to physical healthcare? Do all of these characteristics pertain, or indeed are there other characteristics which may mean it is slightly different, and perhaps there is a market failure and it is pretty pervasive, and how do we respond to that? So I've pulled out a couple of characteristics. There's a whole range of them that I could talk about, but I wanted to just focus on these and use them to kind of try and illustrate why I think mental health might be a little bit different to physical health. So first of all, I'm going to come back to this slide throughout, but let's start by thinking about the prevalence of mental health. So we often talk about common mental disorders, and that's because, indeed, it is common. So if we just look at, from the Global Burden of Disease study, at the worldwide prevalence of some of the big conditions, physical health conditions in the world, from epilepsy through to cardiovascular disease and respiratory disease, which affects nearly over half a billion people in the world. Well, in fact, mental health problems affect nearly 1 billion of the world's population now. So it's very common. But mental health problems actually don't have huge mortality impacts. But what they do have is huge disability impacts, so morbidity impacts. So it's one of the 5th leading causes of disability-adjusted life years. It's among the top 10 causes and over 20% of the disease burden in Europe. And I would argue that despite the fact that there has been this increased priority on mental health in the global health agenda, it still probably isn't getting the action from governments and from international agencies that it should. So there's a very high prevalence, but the other point I'd like to make, where I think it is distinctly different from physical health, is in the nature of that prevalence. So if we just look, this is disability-adjusted life years by age categories and by sex, so males on the left, females on the right. And if we look at the shape of this curve, the shape of this figure, you can see the dark red bits are depression and anxiety. So the highest proportion of disability-adjusted life years are caused by depressive disorders and anxiety, followed by schizophrenia, which is the orange bits. And I think the point I'm trying to make here is that even while we can see some of this happening at very early ages, even under the age of 5, where individuals might experience learning disabilities or ADHD, attention hyperactivity disorder, the majority of this prevalence affects people of working age. And I think that's the crucial distinction from physical health. So where physical health conditions may predominantly affect people in their older age, older years, where medical beds tend to be filled in hospitals by elderly people, here it is affecting people of working age. And that has really different economic consequences. So the next sort of characteristic I want to talk about a little bit is stigma and the impact that stigma and other aspects of mental health have on people tending to avoid treatment, and the impact that this has on what we call the treatment gap. So mental health stigma, I think people don't always think about this, but stigma has real economic effects. And there's been some great work done by colleagues looking at the impact of stigma on employment, income, whether people choose to go to a pub or restaurant or cafe, their religious activities, housing, access to treatment, their health-seeking behavior, and their impact on care contacts. So people tend to want to withdraw from going to see their GP because of stigma. So it has real impacts on resource allocation and healthcare costs. And this results in what we call a welfare loss. So essentially that, again, that loss of economic and social welfare when the market isn't in equilibrium. In terms of avoidance of psychiatric treatment or mental health treatment, there may be a host of reasons. People may not be aware they need help. They may lack insight. They may have not had success in the past from getting care. Their illness may affect their abilities to seek help. But again, stigma can play a big role here in terms of health-seeking behavior. So there are other aspects which may also, besides stigma, as I've mentioned here, which may also impact on people's getting the care and treatment they need. And a key factor of that is financial impacts. So in economics, we talk about moral hazard, which is where individuals have health insurance coverage. They may behave slightly differently. And as economists, we're interested in looking at the elasticity of demand, so how price responsive people are. So if there's an increase in co-insurance, so the proportion that people have to pay out of pocket essentially for their healthcare, how price responsive are they? So this evidence we've seen from the RAND health insurance experiment shows that people are much more price responsive for mental health as opposed to physical healthcare. So for a percentage increase in co-insurance rate, people will reduce consumption of mental health services, mental health care by 0.8%, which is much bigger than for physical health care. It's a very nice study by a PhD student from the Netherlands in 2022 in social science and medicine, which also showed that an increase in deductibles also reduces mental health care. So even though we know there are these financial barriers, when there is no financial barriers and care is free at the point of access, people still tend to minimize contact with services. They don't want to seek help and they'd rather avoid that label. Again, stigma plays a key role here. And this results in a huge treatment gap. So this evidence is quite old now. It's from the previous adult psychiatric morbidity survey. We don't have the most recent one because they're only done every 7 years and it didn't happen during COVID. So we don't know what the sort of treated prevalence of some of these conditions is now. But we know, this is UK data, that there is a huge treatment gap. So people with psychotic disorders, around 2/3 of them might get treatment, but a lot of other conditions don't get the treatment they need. So there's this gap between need and care receipt. And we know for physical health care, in contrast, so 78% of people with heart disease and 91% of people with high blood pressure will receive treatment. So this gap, this treatment gap, we also know is really high in low middle income countries settings. So it's probably around 85% compared to around 40% in high income countries. So another characteristic I wanted to talk about is social exclusion and equity considerations in mental health. So this is quite a crude way of trying to make the point, but it was the best example I could come up with. And this is an older study now, but done by WHO, in which they tried to tackle the determinants of mental health compared to self-report physical health and life satisfaction. And of course, there's a whole raft of factors which could be a determinant of mental health. But here they've just put it into 5 buckets essentially. So health services, income and social protection, living conditions, which would include safe neighborhoods, housing deprivation, living with access to green spaces, and so on. And social and human capital, which would include education, and then employment and working conditions. And you can see here for mental health, the biggest proportion of the determinants of mental health are driven by the green bars, the income security and living conditions. So 46% is driven by income security and 30% by living conditions. So not only is income a big driver as a determinant of mental health, but we also know some good evidence from economists. So, for example, Roy and Schur in Health Economics in 2013 had a lovely study showing the persistence of mental health from one period to the next, and that income is a really strong risk factor for that state dependence. And furthermore, colleagues in Australia, David Johnston and others in the Journal of Health Economics, showed that intergenerational persistence of mental health and how important income was in that as well. So income is important in determining mental health. It's important in the persistence of mental health, and it's important in the intergenerational persistence of mental health. So it's a key factor. If we have poor parental mental health, that the child's future income will also be impacted. And this is just a graph from a piece of work which we hope will come out next week, which we've done with the Health Foundation. And again, I think it just shows really nicely that really strong gradient. This is the proportion of patients in secondary mental health services in England by deprivation decile over 3 financial years. And we can see that in the most deprived decile, there are almost more than double the proportion of patients in the least deprived decile. So income is a really strong driver of people in mental health. Of course, it's fair to say that physical health is important to people's social and working life. But in fact, work by Lord Layard and colleagues at London School of Economics showed that mental health is the biggest single predictor of life satisfaction, more than income, more than unemployment, and more than physical health. So, and again, I think the key point to make here is that mental health is predominantly concentrated among people of working age. So it is absolutely fundamental to our working life and to our social life and life satisfaction. And I think economists are really making important contributions in this space. There's been a lot of work over the last decade or so. So economists have started looking at the causal impact of unemployment on mental health, causal impact of working conditions on mental health, the causal impact of income on mental health, causal impact of mental health on employment. So that reciprocal relationship and the causal impact of mental health on workplace productivity. So there's a lot of work going on in this space, which is really exciting. I think we're starting to unpick some of these endogeneity challenges in a much more fundamental way. And it's great to see so much work happening here. Then just to touch on cost. So there are a lot of costs, but I think the cost of mental illness presents again in a slightly different way to perhaps physical illness. So a study by David McDade and colleagues from the Mental Health Foundation in 2022 showed the mental ill health costs the UK economy around £125 billion per annum, which is around 5% of GDP. In fact, there has been this year a more recent study by the Centre for Mental Health colleagues, which suggested that this figure is probably a lot larger, probably closer to 300 billion. But I'm going to stick with the old figure because we can actually break it down into what the component parts of that are. So you can see that a large preponderance of this is that it falls to economic inactivity, reduced productivity, sickness, absence, unemployment, and so on, and informal care costs. And that absolutely swamps the direct health and social care costs. And the predominance of these costs fall in the working age group. So We know that around 40% of benefit claimants record mental health disorders, the main reason for being off work. That results in lower tax receipts, of course, lower consumption expenditure, a whole range of other factors. So that component of it, the benefits component, reduces GDP in OECD countries, but also the employment component, the lost productivity, absenteeism, reduces GDP in OECD countries by an estimated 6%. So it has indirect costs on a range of agencies, employers, educational, criminal justice, and so on. But also it has major costs on individuals. And probably the most key point, that being the huge decrement to life expectancy that individuals with serious mental illness experience, around 20 years. And largely that is due to preventable physical illness. So it has a huge impact on quality of life, loss of earnings, and so on. And the final point I'd like to make around cost is just while we know there are some advances in cost-effective treatments which can alleviate some of these high social costs, the challenge with mental health is that a lot of these costs may fall to the health system, but a lot of the benefits accrue elsewhere, and sometimes that might be a barrier to why some treatments might get introduced. So I just want to give this example. This is quite an old study now by David McDade and Martin Nath from London School of Economics, but I think it illustrates the point so nicely. So it's a study where they took a whole range of cost-effective interventions and looked at the sort of economic payoff for them. So if you were to invest £1 in this intervention, what would the payoff be for the NHS, for the rest of the public sector, so education, criminal justice, etc., and for the wider economy, if you like, the non-public sector. And if I just took two examples, so for example, early intervention in psychosis. So here we have an intervention which is about getting teams of people to proactively look after people with psychosis, to reduce their relapse and readmission rates, to improve their chances of returning to employment, education, training, and so on, using a multidisciplinary team approach. We know this is a cost-saving intervention. The payoffs for the NHS for that £1 investment are large, probably around £10, but there's also a huge payoff for the wider economy. So if we took another example, suicide prevention, by introducing bridge safety barriers. So jumping accounts for about 3% of completed suicides, and if we construct these safety barriers, it tends to not displace them to other jumping sites. It could displace it to other means of attempted suicide, but the fatality of those generally is lower. So the evidence from this came from a Clifton suspension bridge in Bristol, which was a real hotspot for jumping, and it was shown to be hugely effective, reduced suicides by literally half in the period before compared to after. The impact of this for the wider economy is absolutely enormous in terms of reduction in lost productivity, earnings, consumption expenditure, etc., etc. So this is perhaps one area where there is overlap between physical and mental health, physical and mental illness, because a lot of illness nowadays presents in a very, very heterogeneous way. A lot of people in medical beds present with mental health problems as well. In fact, I think the estimates around 2/3 of them have mental illness as well. But I just wanted to make the point about the rates of physical illness being much higher for people with serious mental illness compared to the general population. So they're 5 times more likely to have 3 or more physical health conditions compared to the general population. 40% of all tobacco is smoked by people with mental illness. They're much more likely to experience significant weight gain and metabolic disorders from antipsychotic medication and so on. So this is just showing you the risks, the higher risks experienced by the younger group of people with severe mental illness, aged 15 to 34, compared to the general population with respect to obesity, asthma, diabetes, and hypertension. So they're much more likely to suffer from these preventable, often preventable physical illnesses. As I said, many people with physical illness also present with comorbid mental illness. And that also has all sorts of economic implications in terms of reduced adherence to treatment, increased cost, longer length of stay, poorer health outcomes, lost productivity, and so on. In terms of jointness and production, I think this is something where mental health is rather different. Imagine you go to see a dermatologist and perhaps you need to have see a plastic surgeon as well for an excision of something. The number of agencies that need to be involved in that care are far fewer than compared to mental health. So if we look at mental health, this is again a diagram from WHO, which just shows the multitude of agencies that might be involved in the production of mental health care: social services, acute services, primary care, prison services. And this has been much more prevalent with deinstitutionalization of mental health care, resulting in kind of case management approaches to coordinate care, use of multidisciplinary teams. So the provision of care is much more multi-agency, thinking about housing, employment, education, training, criminal justice, and so on. It's also very often organized and funded differently. So typically, there's a much higher share of funding which will be public because of all these market failures that we've described, so compared to physical illness. And mental health, I think, given the burden of disease, is also very often underfunded. So in 2005, WHO affirmed the responsibility of governments to ensure that mental health receives sufficient resources given the burden of disease, and that investment must make an identifiable part of health expenditure. I think that's the crucial part, to receive parity with health. So, for example, in the UK in 2012, the Health and Social Care Act enshrined that parity of esteem between mental and physical health. And I think in the UK, we are still struggling in a lot of areas to make sure that happens. If we think about waiting times and so on, that parity doesn't exist yet. So just to illustrate the share of mental health spend as a proportion of total healthcare expenditures and as a proportion of GDP for low-income countries versus middle-income versus high-income countries. So high-income countries spend around 5% of the healthcare budget. So, for example, in the UK in 2021-22, we spent about £12 billion, which I think is about 8% of the NHS budget. So we spend generally certainly more than 5%. It's quite difficult to come by accurate figures for this. So this graph is quite old now. But you can see in low-income countries, this is extraordinarily low. It's actually quite difficult here to identify that identifiable component being for mental health, I think, is really quite low. And finally, I wanted to touch on some of the challenges in measuring outcomes and performance in mental health. So if we think about, measuring, using EQ5D as a measure of quality of life, which is widely used, I think it's questionable whether this is suitable for mental health. Equally, if you think about how an individual with who might be suicidal, whether they might place higher utility on death than on life. So I think there's a huge number of challenges in terms of measuring health and health status in mental health. We have very different measures of mental health and well-being, lots of different tools. Often they self-report, they're not clinically validated, and they may measure very different aspects of mental health functioning. So I think there's a lot of challenges in measuring outcomes. And an additional point I wanted to make, I think, is best illustrated through this graph, which is, again, quite old work now, which I did with a colleague published in Social Science and Medicine some years ago. And this uses the Health of the Nation Outcome Scale, which is a routine measured, clinician-rated outcome measure in England in healthcare services. And what we did here is essentially look at before and after treatment, the change in outcomes based on HONOS, and divided it into these categories from reliable and clinically significant deterioration through to improvement. And you can see that over 80% of patients remain stable. Now, we also collect routine outcome measures for hip and knee surgery in England before and after treatment. And if you look at the changes in outcome for those, you will see that the vast majority of people show significant improvement. So you may well ask yourself, well, how is it that we're investing millions of pounds in mental health treatment compared to physical health? We can see that there is an improvement, whereas for mental health, most people are just staying stable. What's going on here? And I think the point to make here is that actually, given it the nature of mental illness, given the episodic nature, and many of the conditions not always being readily treatable, actually keeping somebody stable is a really good outcome. And I think we need to be thinking about how we measure outcomes, and if there's a better way in which we can be addressing this and getting this message across to policymakers as well. So how, as economists, do we think about this? And some of the challenges with measurement, I think, abound in mental health in terms of the lack of data we have, the poor quality data we have, the challenges we have to cost data, and this results in really large variations. So this is some work which we did where we costed up psychotic care using two different approaches, a sort of top-down approach and a bottom-up approach. And you can see along the y-axis here, we've got the 55, 60 mental health providers, and just the enormous variation between mental health providers in terms of the cost of delivering care for patients with psychosis. Absolutely enormous variations from less than £100 through to £14,000 per annum. We also see here along the x-axis this time we have the 55, 60 mental health providers with hugely different lengths of stay for mental health patients. So again, this is some work we did quite some time ago, but I think it just demonstrates that huge variation. So we've talked about a whole range of characteristics. There are many more. I'll just whip through them very quickly, and then I promise to stop for some questions and discussion. But some of the other characteristics which Kenneth Arrow brought out, I think, also pertain to mental health, just in terms of thinking about the high degree of uncertainty. So we don't have a magical blood test or X-ray which can tell us whether somebody has a mental health condition. So there are no definitive tests. So there's a lot of uncertainty around diagnosis. There's a lot of uncertainty around prognosis, the unpredictable nature of the illness, whether it's going to be a complete or a delayed or partial recovery. Some mental disorders are not curable. So there's uncertainty around prognosis. There's often also an uncertainty around the effectiveness of care. So I think uncertainty certainly looms quite large. We can think about a number of externalities. So these are those spillover effects, which I think, again, are pervasive. So someone's behavior can influence the costs and benefits faced by those around them. We can think of many examples. So somebody having a family member who's affected by mental illness, informal carers, or individuals with mental health problems displaying unusual or unpleasant behaviors which may distress others. Individuals may be a threat to themselves or to others. And so again, these externalities, I think, probably loom quite large. If we think about that agency relationship again, that relationship between doctor and patient, I think sometimes for mental health, this is quite a bit more complex, particularly if we think in the context where a lot of patients may be detained against their will for treatment. So your doctor here is not only your caregiver, your provider of care, but also your jailer. So I think again, these are make this relationship quite complex. Mental health patients may not always be able to express their preferences due to the nature of their illness. They may not have insight. They may not be able to make utility maximizing choices. They may exhibit socially unacceptable preferences. So again, I think there's some bigger challenges perhaps here. And in terms of information asymmetries, again, doctors may not be able to know a patient's preference set. Patients may not be able to express it. There's this complex asymmetry, particularly if a patient is detained. And then I think the restriction of individuals is a real is something which is really quite different compared to physical health. So it's very rare for involuntary treatment for people with physical illness, but for mental health problems, we can detain someone, we can restrict them so they experience a loss of their right to liberty. And in the UK, that is done through the Mental Health Act. So a couple of concluding thoughts then before I stop, and hopefully we have enough time for questions and discussion. Is mental health different to physical health? I would argue probably yes. I think there are these important departures from the competitive paradigm, which are really pervasive. Of course, they exist in physical health. I would, I'm being quite broad brush here, but it's to try and sort of make the point that I think there are quite important characteristics and features of mental health that distinguish it from physical health. And as a result, I think that government intervention, as we've seen, it's more likely to be funded by public money, and government intervention is far more likely. And so as economists, I think we need to think really long and hard about the importance of the contributions that we can make in this space. And I think we can really contribute much more to the understanding of the economic impacts of mental health. I think economists are doing a great job of doing that, but I suppose this is in some ways a call to arms that we need more people in this space to understand better the impacts to society, to health services, to the economy, to individuals, and so on. So there's a huge number of challenges which I've just alluded to today. Some of those are around that big treatment gap that exists, the access to care, the immense inequalities experienced by individuals, right through from inequalities in suicide rates, inequalities in mental health act detentions, inequalities in housing, and a whole range of things. I think there's a huge amount more work that we should be doing around that physical multimorbidity, mental health multimorbidity space, and especially post-pandemic. So again, there's been an unequal impact of the pandemic on people, particularly those with severe mental illness, which I think more needs to be done around. And I think, again, because I've hopefully tried to demonstrate some of those spillover effects that exist in mental health, I think we need to think more, do more of the sort of system-wide evidence for policymakers on those spillover costs and benefits, and think of this more rather than just thinking about the healthcare system, but the wider economy and impacts. And I think ultimately there are these bigger societal challenges which need to be addressed in order to try and alleviate some of the challenges in terms of the determinants of mental health, thinking about the socioeconomic inequalities, poverty, social fragmentation, living conditions, the climate, and so on. So I hope I've provided some food for thought. I have a final very cheeky slide, which is just to say that we have 2 research fellow positions open at the Centre for Health Economics at the moment. If anyone is interested, please look at our website. So thank you very much, and happy to open the discussion. I think I will stop sharing my screen now.
Thank you, Rowena, for your nice and very informative presentation. I believe that our participants enjoyed it and would be interested to work on mental health from their available field of research. So I have one question uh, on chat box. I'm reading it for you. The question is, what do you further comment on the estimation approach for cost of stigma and discrimination on mental health? This is the one question I have in chat box. Yeah.
That's a great question. So
Yeah.
uh, there is a colleague, Graham Thornycroft. Sorry, it took me a moment to get his name. He's probably an economist who's done the most work around the economic cost of stigma, and many of the studies that I was referring to are things that he's done. So there is a sort of index that you can use to measure the cost of stigma. There have been some studies looking at cost-effective interventions for stigma, to address stigma. There haven't really been any studies looking at long-term impacts. So most of the sort of cost-effective interventions seem to suggest quite short-run effects. Um, but I think there are studies looking both at individual level and at population level. So interventions to address stigma at an individual level versus a population level. I think some of the, if I recall, some of the population level studies seem to show the greatest effect. Yeah, I would recommend looking at some of the work by Professor Thornycroft. I think he's done probably most in this space. I hope that helps.
Okay, I think two other questions. One is, how can economic policies better support mental health programs in low resource settings? One. Another is, how to quantify the economic impact of untreated mental health conditions on society? Uh, two other. Can I read all these things together or one by one?
Yeah, we can. Shall we start with those ones?
Yeah.
Um, so, so how to quantify? Let me start with the second one. How to
Yeah.
quantify? Um, let me just the impact of untreated mental health conditions. So I think this is where we need good studies to measure unmet need, um, and and sometimes that's quite difficult. So, for example, I've been doing some work looking at the unmet need for children and young people. It's quite difficult because whether you assess whether the parents are saying they have unmet need versus the child versus the care provider, they all have different views on what that unmet need is. So we need to think very carefully about how to define unmet need in different circumstances for different conditions. But I think that's essentially the starting point for trying to then look at that treatment gap and how to start addressing it. In terms of low resource settings, economic policies to better support low resource settings, I think we need more people in low income countries to take up the mantle of working on mental health challenges. And I know, having done a little bit of work in low resource settings in various countries now in Southern Africa and South Asia, that unfortunately mental health is often the one area which gets displaced when resources are constrained. Indeed, that actually happens in high income countries as well. So in the UK, for example, when resources are constrained, because we haven't had any kind of transparent funding model for mental health ever, really, when resources are constrained, the funding that is available tends to get displaced towards physical health care or emergency care and gets taken from mental health care. And that's happened time and again in high income country settings. I think one way of dealing with that is to go back to that notion of having an identifiable and I would argue ring-fenced budget for mental health. So having a transparent funding which is dedicated towards mental health, probably the first recommendation I'd have in that regard. Do you want me to start looking at some of the other questions? A couple more here.
Yeah. And the next one is, can you comment on how investing in mental health services leads to long-term cost savings in healthcare? one, and then the next one is one of challenges in terms of economic evolution, mental health services or intervention is defining cost. Are there any specific tools or method except direct, indirect, etc., to detect correct form of cost in mental health in UK particularly? And lots of questions, I
Okay,
think.
well, why don't I start with those two? So,
Okay.
this is a fantastic question. So in terms of investing in mental health services and long-term savings to the cost of healthcare, we are in fact examining this exact question at the moment in the UK context. So I'd love to say, can I answer that question in 12 months' time? Because then I can hopefully give you an answer. But what I expect is, so what we're doing is we're looking at if you invest in mental health, say in 2015, what are the impacts on costs for um, uh, the health service in 2017, 18, 19, and beyond, um, in accident and emergency care, in physical health care, and in mental health care. And my expectation is that if we invest in mental health care, it should reduce future costs. And the reason for that is um, if we intervene early in mental health, of course it's true in physical health too, but I think it's particularly so in mental health. If we intervene early, the long-term payoffs in terms of being able to keep people in employment, being able to keep them in education, um, the impacts on the wider economy and on the health service will be huge. Let me answer that question more fully in 12 months' time, but that is certainly my expectation. I think it's a great question. The next one was in terms of economic evaluation is in defining costs, are there specific tools? My expertise is not actually in economic evaluations, but the costing that we've done, we've used different approaches, um, using kind of top-down methods of costing. So taking essentially the mental health budget and breaking that down by different unit costs, by different conditions, and so on. And then also a sort of bottom-up costing approach. And I can recommend the paper that was with Ride et al. Colleagues, which we did in Applied Health Economics and Health Policy, which tries to unpick some of that costing methodology in a UK context, if that's helpful. We didn't in that particular example, though, we were just looking at healthcare costs, not the wider economic costs. So there, obviously, it's more challenging to try and unpick those indirect costs. And I think that's why when we look at the impact of mental health on the economy, some of these studies come up with very wildly different estimates, because estimating the economic costs of absenteeism, presenteeism, lost productivity, and so on is really, really quite challenging. But there are some of these studies, as I referenced earlier, that are starting to unpick that. Shall
Okay, I think, Rowena, we have four more questions and we have seven more time.
Okay.
So minutes. And so the next question is, how does the economic burden of mental health disorders compare between developing and developed and developing countries? And then another one is, could you kindly discuss how technology can improve accessibility and reduce cost in mental health care, especially for the era of AI and data science? And the next one is how mental health funding is prioritized within overall healthcare budgets. And the last one is, what are the economic barrier to accessing mental health care and how can they be addressed?
Okay, so all great questions. The economic burden of mental disorders in different countries. I suspect we haven't even scratched the surface in developing country context. And if you look at the proportion of funding that's spent in low-income countries as a proportion of GDP and as a proportion of the health budget, is absolutely minuscule compared to what I suspect is the burden of disease. And if we think of countries, particularly war-torn countries, the high conflict countries, the amount of mental health trauma that must be experienced there, I suspect that impacts, as I said, not only that individual, but has that intergenerational component. So I suspect the burden of disease would be probably far greater in developing countries, and the relative resource that is expended on it is probably significantly lower. And I suppose, again, this is that call to arms for people in low middle income countries to take up this mantle and to do more work in this space, and to bring awareness to this, this important area. The role of technology, that's a great one. So if we look over the last 50, 60 years in terms of the sort of trends, the sort of supply side trends in mental health, we've moved away from institutionalized care, we've moved towards community-based care. Pharmacological interventions are sort of the mainstay, alongside psychological interventions for most conditions. But I can see a move, and I think also post-pandemic, there have been trends globally towards remote provision of care. So I can see an important role for telepsychiatry, if you like. You know, there's a lot of apps and so on that are available for mental health support. However, very few of them have shown any sort of cost effectiveness or clinical effectiveness. Very few of them have been tested. So there's a huge amount of work to do in that space. I think the number of apps and so on are in abundance, but whether they are sort of evidence-backed is very questionable. So I think probably a lot more work to be done in that area. But I think there's certainly a trend towards sort of telepsychiatry, and I think there are cost-effective ways in which that could be rolled out, and probably in resource-constrained settings that may be an area of future exploration. How can we ensure that mental health funding is prioritized within the health budget? I think that's something which is so crucial, and which even in the UK context has not happened. So, for example, in the UK, for many, many years, we've had a very transparent funding approach to physical healthcare and a very opaque one to mental health care. And as a result, when budgets are constrained, if you don't know what you're spending your £120 million on for a particular mental health provider compared to what you're spending your £120 million on for an acute provider, and you know you're getting 30,000 varicose veins, 2,000 hip replacements, 4,000 cataract surgeries, etc., but you have no idea what you're getting for mental health, it's very easy to say, well, we'll just take 5 million off that budget and give it to acute care. And that's been happening in the UK context repeatedly. So I think having ring-fenced budgets, so since I want to say 2019, I think, clinical commissioning groups here in the UK, or up until, yeah, well, they've changed name now, they're not clinical commissioning groups anymore, but we have a ring-fenced budget essentially for mental health investment, the mental health investment standard. So I think that's probably the first starting point, is to make sure that we don't steal from Paul to give to Peter, and that gets prioritized. What are the economic barriers to accessing mental health care, and how can they be addressed? So again, I think I mentioned some of those being financial barriers. So where care is not free at the point of access, we know that there are financial barriers. So people are much more likely to reduce consumption of mental health care compared to physical health care. So that is a main economic barrier. So I think in the US, for example, they've done some great studies looking at the barriers of access to people with severe mental illness, and lack of insurance, or incomplete insurance, or inadequate insurance are some of the key barriers. But there are a whole range of other things as well. And again, stigma being one of them, lack of health-seeking behavior on the part of the individual, because they don't, they may not have insight, and all the various factors that I mentioned. But certainly financial barriers are a key one. And how can they be addressed? Well, I suppose universal healthcare is a key one, but there are a whole range of things. If we start trying to co-produce some of these solutions with people with mental health problems, I think we'll hear from people with mental health problems how to address some of these issues. So, for example, there was a great study. I've been involved in a lot of work trying to look at getting people with severe mental illness to have routine physical health checks. And as part of that work, we spoke to people with mental health problems, and they said, you know, the way you invite us to those physical health checks really matters. So if we feel threatened, we're not going to come for those physical health checks. But if the way, do you send a letter? Do you send us text reminders? You know, so speak to people with mental health problems. Ask them how they want their care to be addressed, and they can tell you. And that made a huge difference in terms of how these reminders were sent to people. So I think there are a number of these barriers, but if some of these solutions are co-produced, that's probably one of the best ways to start addressing those. What role do mental health interventions play in improving workplace productivity? This is another great one. And again, actually, Simon and I are going to be doing some work in this space. I want to commend some work by a colleague of mine, Claire de Oliveira, who's done a systematic review looking at interventions to improve workplace productivity. So if you look up her systematic review, that it can give you much more detail on that, but a key one around that is cognitive behavior therapies and other psychological interventions, which are shown to be cost-effective. Employment advisors also been shown to be cost-saving. I'm not sure about cost-effective. So, but yeah, probably the main one in that particular space would be CBT. But have a look at the Oliveira study. Yeah, that's probably, I think, all we have time for.
Okay, thank you, Rowena, and thank you everyone for joining with us. I think it's a great discussion. So I hope that everyone enjoyed it. Yeah. Simon, do you want to say anything?
Uh, yeah, just to say thanks again to Rowena for a really interesting talk, and thanks for everyone for attending. It's really good to see so many people here. There will be another seminar, a webinar coming up in December, I think, which we'll share the details around. But yeah, just thanks to everyone again, and enjoy the rest of your day.
Thank you very
Okay,
much.
Thank you.
Thank you all.
bye.
Bye.